So the next session is on chronic pancreatitis complications. This session is sponsored by Sun Pharma. So let me invite the moderator and chairpersons. Dr. Mohan Reddy, Professor of Gastroenterology, Kannur Medical College. Dr. Prem Kumar, Professor of Gastroenterology, Madras Medical College. And Dr. Vishnath Reddy, Senior Consultant Gastroenterology, Yashoda Hospital, Hyderabad.
Very good evening. We just finished the initial talk by Dr. Nihal Thomas. We'll go to the next talk. It's on nutritional deficits in chronic pancreatitis, role of micronutrients and sarcopenia by Dr. Samagra Agarwal.
So good afternoon everyone. At the outset I would like to thank the IPC for inviting me for this talk. And I'd like to start with a case scenario, but that is more of a story that we very often see. My slides are not moving. Yeah, okay. So we have a 30 years old male who works as a security guard. He has known chronic pancreatitis and has been on irregular follow-up for around 10 years. He is not an alcoholic, he used to smoke but has stopped. He had some pain initially but now has been pain-free for the past 2 years. The most concerning thing for him right now is his poor physique, and he has been advised enzyme replacement therapy for that, and he takes it as needed according to him. And you examine him, he is cachexic, he has a BMI of 16, his all blood parameters appear to be normal, his blood sugars are slightly high, and he's taking insulin for that, but his body physique continues to be in that form. So what next? So had this patient appear some 20 or 25 years from before this, he would have been labeled as something known as tropical chronic pancreatitis, and the idea at that point was that essentially the malnutrition in some patients can get so intense that it can essentially induce pancreatitis on their own. So this is a review back from 2003 when the entity was discussed, and just focus on the idiopathogenesis. Malnutrition as a pathogenesis and trace element deficiency as a pathogenic factor for tropical chronic pancreatitis. However, we are at the fag end of the second day of this conference and we haven't heard of this terminology, and it is surprising to see that even as late as 2008 there were studies where people were wondering whether malnutrition is actually a cause or an effect of chronic pancreatitis. And the study obviously showed that patients with idiopathic chronic pancreatitis essentially had a similar nutritional status prior to the onset of pain. So it was probably the pain that was driving the development of malnutrition instead of the malnutrition driving pancreatitis per se. We have come very far in our understanding of chronic pancreatitis, and obviously now we know that it is not as simple as malnutrition driving pancreatitis or pancreatitis driving malnutrition, but it's a set of proximate principles. We will have pancreatic insufficiency, a set of patients will have alcohol abuse, there may be diabetes, there may be pain, there may be low appetite, there may be mood disturbances like anxiety and depression. And all of this would ultimately have a set of local effects and a set of systemic effects. In local effects, the inflammation and fibrosis and all the calcifications will be predominant, while in systemic effects we'll see a lot of malnutrition, which is probably best documented by sarcopenia or the lack of functional muscle mass in that patient. And ultimately it translates into the worst quality of life. So where do the micronutrients fit in, and how do we focus on micronutrients? So let's focus on a bit of science about the micronutrients. So we all know that micronutrients are essentially a part of the diet where we classify all the nutrients that we consume into macronutrients, which are required in the dose of grams and are perhaps the main source of energy for the body. And then there would be some micronutrients which would be essential to maintain health, but they are required in very small amount. And then we would have water-soluble vitamins and fat-soluble vitamins, and then there would be a set of minerals which are again required in slightly higher amount or a lower amount. And the fat-soluble vitamins would be the one which would perhaps be the maximum affected by chronic pancreatitis, because there would be a deficiency of lipase and a lot of other enzymes that will lead to fat malabsorption. And micronutrients are very closely linked to the redox status. So here we can see that we have a set of fat-soluble vitamins and water-soluble vitamins. And on one end, the fat-soluble vitamins will take up all the oxide radicals, which are essentially causing alterations in lipids and lipid peroxidation, and that is being scavenged by vitamin E, and then that is being further regenerated by beta carotene, vitamin C, glutathione, and there could be a role of multiple other ions like selenium, zinc and copper, which would then go on to regenerate this. And this was the basis for Braganza and others to suggest that antioxidant micronutrients are perhaps very closely linked to the pathogenesis of chronic pancreatitis. So they propose that a set of risk factors like alcohol, smoking, non-esterified fatty acids, some foods, some presence of some kerosene fumes, and in an appropriate genetic background would perhaps induce CYP enzymes. And this CYP would lead to generation of reactive oxygen species and reactive sulfation species, which would then be scavenged by glutathione, and this would lead to glutathione depletion. And because there would be a corresponding micronutrient deficiency as well, so then methionine, vitamin C and selenium would then go on to, and in their absence the glutathione will not be repleted, and the balance would be tilted in favor of more inflammation, and that will lead to mast cell activation, stellate cell activation, and finally pain, inflammation and fibrosis. But where does the evidence stand on this? So we all know that micronutrients will perhaps be deficient in chronic pancreatitis, and that is somewhat obvious. So when we look at fat-soluble vitamins like vitamin A, D, E and K, all of them are deficient, and water-soluble vitamins are also deficient, but the level to which they are deficient is perhaps lower, as has been shown in a multiple set of studies. And there is a significant amount of data now to show that perhaps there is some improvement in pain with very limited adverse events in painful chronic pancreatitis. And I would like to draw your attention to this Cochrane review back in 2014, where we see that while the number of pain-free participants had some overlap, the relative risk had some overlap, the amount of pain reduction was actually quite good. And while the quality of evidence overall was low, there is some evidence to suggest that there may be some reduction in the visual analog score for the pain as well. So how does this all translate into practice? So first of all, assessment of sarcopenia could be important, because a patient, irrespective of the amount of BMI, could have different amount of muscles in their body. So for example, a patient who is underweight would have very little fat but would have some amount of muscle, and at the very same time a patient who is obese could have a relatively high BMI but the amount of muscle in that would actually be quite low. So this has been recognized by numerous guidelines as well. For example, the ESPEN guideline says that BMI alone should not be used to assess nutrition in patients, and because it does not probably register sarcopenia. Obviously, the right method to measure sarcopenia that is feasible and easily available in all clinical settings is still up for debate. And then finally, we would also want to document exocrine pancreatic insufficiency. Now, that is another part of the equation that is perhaps requires a talk on its own, but there could be some merit to staging exocrine pancreatic insufficiency beyond just fecal elastase levels. So in this study, they had proposed that instead of just focusing on fecal elastase levels, there could be some benefit to adding coefficient of fat absorption and some serum vitamin A and E levels to grade the exocrine pancreatic dysfunction into stages from stage 1 to stage 4, and that could perhaps guide management by deciding whether enzyme replacement and micronutrient supplementation is required. We had also evaluated the utility of fecal elastase in our setting, and we had compared it to fecal fat more than 7 grams per day, and we found moderate association. So for example, in this receiver operating characteristics curve, we see that 70%, almost the ROC curve area was around 0.7. So 70% of the variability in the fecal elastase could be explained by changes in fecal fat. But when you actually see the graph where we are trying to see the variations in fecal fat and fecal elastase, it is all over the place. And probably fecal elastase is giving you some information, but it is not all the information that can be extracted from a fecal fat study. So this had led us to propose that it could be relevant to grade the fecal elastase into again categories of less than 20 or more than 20, and among patients who had a fecal elastase of more than 20, and if they had any clinical features of pancreatic exocrine insufficiency, it could be worthwhile to do a fecal fat test to actually document whether pancreatic exocrine insufficiency was there. So the micronutrient deficiency, the guidelines, SPEN guidelines say that patients should undergo screening for micro as well as macronutrient deficiency at least every 12 months. The feasibility of this obviously remains in question, and whenever there is a clinical sign of fat soluble or water soluble vitamins, it should be identified, and the supplementation should be proposed in patients who have a known malabsorption or any clinical signs of deficiency. Now obviously all this I have presented leaves us with perhaps more questions than the answers that we can have in this field. So for example, what about subclinical micronutrient deficiency? Does it actually have a long-term impact on disease course and quality of life? The disease course being the exocrine function, the endocrine function. We still do not know that. Could there be any biomarkers of micronutrient replenishment? So we all know that whenever we give any micronutrients, the levels rise rapidly. But is that the true level, or is that representative of the actual micronutrient status in the cell of the body? That remains unknown. What is the cost effectiveness of testing and treating versus treating all patients with micronutrient supplementation? And then what could be the right frequency for monitoring such patients? And then how do these micronutrients interact with enzyme replacement? So coming to the take-home messages, do not miss the obvious. Try to always make sure that the patient is abstaining from alcohol and smoking, and they're taking frequent small meals with a balanced diet. The diabetes is well controlled. Try subcategorizing PEI severity beyond fecal elastase levels by making a clinical assessment. And fat soluble as well as other micronutrients should be supplemented if some clinical deficit is apparent. And antioxidant micronutrients may be beneficial in painful CP and should be considered on a case-to-case basis. So on this day of Teachers' Day, I would like to thank all the patients who come to our OPDs and teach us all that we present here. Thank you.